Welcome back to the deep dive. Today we're jumping right into a really crucial topic for anyone prepping for the NAPLEX HIV.
Absolutely. It's complex, but so important.
Before we really get into the weeds, though, let's start with something a little different. Just take a moment. If you can, close your eyes or just soften your gaze. Take a deep breath in and slowly let it out. Now try to bring to mind one person, maybe a moment, or even an opportunity in your life that genuinely brings you joy. Could be a family member, a small win you had recently, or honestly, just the chance to be here learning today. Just hold on to that feeling for a second, that sense of joy or gratitude. There's actually science behind this. Studies show this kind of emotional shift can prime your brain for deeper attention, better learning, and stronger retention.
It's a great way to get centered.
Exactly.
Yeah.
So let's try and carry that positive energy forward as we tackle this high-impact topic. HIV really blends hard science with empathy and professional responsibility. All right, deep breath over. Now, before we officially dive in, if you're finding these focused, high-yield reviews helpful, please think about subscribing to the channel.
Yeah, it's a small thing for you, but it really helps us grow this learning community.
Helps us make sure more students like you get the support they need. Okay, enough preamble. Let's get to it. Our mission today.
To give you a solid NAPLEX-focused understanding of HIV, we're covering diagnosis, treatment, prevention, the works.
And we're grounding this in solid information, right?
Yes. Our main source is McGraw-Hill's MELX Review Guide, 5th edition, specifically Chapter 27, Human Immunodeficiency Virus by Anushka Burde and David Hatchie.
Excellent. So by the end of this, what should you, our listener, be able to do?
Well, you should be able to understand the basics of HIV pathophysiology, how the virus replicates. You'll be able to identify the key diagnostic strategies, things like the 4th-gen tests and viral load. We'll also help you apply the treatment guidelines, know those initial RT regimens, understand resistance testing.
And critically, know the key side effects, those tricky drug interactions, and what monitoring needs to happen.
Exactly. Plus, how to counsel on PFP and PAP, think about adherence issues, and really lock in those facts you'll need for patient scenarios and drug safety questions on the exam.
Sounds like a comprehensive plan. Let's start breaking it down.
The foundation, what it is, and how it spreads.
Okay, let's lay the groundwork. What exactly is HIV? Why is it still such a major focus?
Right. So HIV human immunodeficiency virus is a retrovirus. That's key. It specifically targets the immune system, primarily the CD4 plus T cells. These cells are, essential for fighting off infections. If HIV isn't treated, it can progress over time to AIDS, acquired immunodeficiency syndrome.
And AIDS is when the immune system is severely damaged, making people vulnerable to opportunistic infections.
Precisely. Infections that wouldn't normally be a problem become life-threatening. Now, in the U.S., we're mostly dealing with HIV-1, so that'll be our main focus. There is an HIV-2, but it's less common here.
And it's crucial to understand, isn't it, that modern treatments, ART, have been revolutionary. People can live near normal lifespans now.
Absolutely. ART, antiretroviral therapy, has been a game changer. But, and this is a big but, for the NAPLEX HIV cannot be cured.
Why is that?
Because it's a retrovirus. It integrates its genetic material right into the host's DNA, our DNA. It creates what we call a latent reservoir.
Like hidden copies of the virus tucked away in cells.
Exactly. They can lie dormant, and that's why continuous therapy is absolutely essential. If you stop treatment, the virus can emerge from these reservoirs.
Okay, that makes sense.
Yeah.
So given it sticks around, how does it actually spread? What are the key transmission routes we need to know?
There are 3 main ways: sexual, parenteral, and perinatal.
Let's take those one by one. Sexual transmission.
Okay. The highest risk comes from receptive anorectal intercourse, then receptive vaginal intercourse. Insertive sex generally carries a lower risk. For men in the U.S., the most common route is male-to-male sexual contact. For women, it's typically heterosexual contact.
And other factors can increase risk.
Definitely. Having other STIs, especially those that cause genital ulcers, significantly increases the risk of both acquiring and transmitting HIV.
All right. What about parenteral?
Parenteral means through blood or body fluids. The main cause here is sharing contaminated needles, usually for injecting drugs. Needle stick injuries in healthcare settings are another, though much less common route. And thanks to rigorous screening, the risk from blood transfusions or organ transplants is incredibly low now.
That's good news. And the third route, perinatal.
Yes, mother-to-child transmission. This is the most common way children get HIV. It usually happens during pregnancy, labor, delivery, or sometimes through breast or chest feeding.
But this is largely preventable now.
Hugely preventable. With effective RT for the mother during pregnancy and sometimes treatment for the baby after birth, the transmission rate in the U.S. is now less than 1%. It's a major public health success story.
That's fantastic. So just to be absolutely clear, what doesn't transmit HIV? There are still a lot of misconceptions out there.
Right. Casual contact poses no risk. We're talking hugging, shaking hands, sharing utensils, drinking glasses, none of that. Saliva, tears, sweat, unless there's visible blood mixed in, don't transmit it. Toilet seats, insect bites like mosquitoes, just being in the same room or breathing the same air, absolutely zero risk.
That's vital information for patient counseling.
It really is. And one other key factor influencing transmission risk is the infected person's viral load.
Okay.
Yeah, the amount of virus in their blood. Risk is much higher when the viral load is high, which typically happens very early after infection, before diagnosis, or late in the disease if it's untreated. The HIV life cycle and drug targets.
Okay, let's get into the nitty-gritty biology. Understanding the virus's life cycle is key to understanding how the drugs work, right? Can you walk us through it?
Absolutely. It's a multi-step process, and yeah, each step is a potential drug target. It starts with binding and attachment.
The virus grabbing onto the cell.
Exactly. HIV has a protein on its surface, GP120, that binds tightly to the CD4 receptor on our immune cells. This binding is helped by other receptors on the cell surface called co-receptors, mainly CCR5 or CXCR4.
Okay, so it attaches. Then what?
Then fusion. Another viral protein, GP41, helps the virus's outer envelope fuse with the host cell membrane. Think of it like merging two bubbles. This allows the virus's contents to enter the cell.
Once inside.
It uncoats. The protective shell breaks down, release the viral RNA and enzymes, and then comes the really unique retroviral step, reverse transcription.
This is where the retro part comes in.
Precisely. HIV carries an enzyme called reverse transcriptase. It reads the virus's single-stranded RNA genome and makes a double-stranded DNA copy. This is kind of backwards from how our cells usually work, hence retro.
And you mentioned something about this enzyme being sloppy.
Yes, that's crucial. Reverse transcriptase makes a lot of errors. It's not very accurate. This leads to constant mutations in the viral DNA.
Which means
the virus changes rapidly. This is a major reason why drug resistance can develop so quickly and why developing an effective vaccine has been so incredibly difficult. That sloppiness is key to remember.
Wow, okay, so after the DNA copy is made,
that viral DNA travels to the host cell's nucleus. There, another enzyme called integrase inserts or integrates the viral DNA right into the host cell's own chromosome.
so it becomes part of our DNA.
Essentially, yes. This integrated viral DNA is called a provirus, and because it's part of the host DNA, it gets copied every time the cell divides. This creates that persistent latent infection we talked about, the reservoir. It's why treatment has to be continuous.
Right, the hidden copies. So how does the virus actually multiply then?
The host cell's own machinery takes over. It reads the integrated viral DNA replication and makes new viral RNA and messenger RNA. The mRNA is then used to make viral proteins. These new RNA strands and proteins then move to the cell surface and assemble into new immature virus particles. They bud off from the cell.
Immature particles.
Yes. There's one final step. Another viral enzyme, protease, cuts the long protein chains inside the new virus particle into smaller functional proteins. This allows the virus to mature and become infectious, ready to infect other cells.
It's a complex dance. So connecting this back to treatment, how do our drugs interrupt these steps?
It maps directly onto the drug classes. We have entry inhibitors that block binding or fusion, think Maraviroc blocking CCR5 or Enfuvirtide blocking fusion. Then for reverse transcription, we have two big classes, NRTIs, nucleoside-tied reverse transcriptase inhibitors that get incorporated into the growing DNA chain and stop it, and NNRTIs, non-nucleoside reverse transcriptase inhibitors that bind directly to the enzyme and inhibit it differently.
Got it. NRTIs and NNRTIs hit reverse transcriptase.
Right. Then we have NSTIs, integrase strand transfer inhibitors, which block that critical integration step. No integration, no persistent infection.
Makes sense. And the last step, maturation.
That's where PIs, protease inhibitors, come in. They block the protease enzyme so the new virus particles can't mature properly and become infectious.
So multiple targets.
Exactly. And there are even newer classes like capsid inhibitors, such as lenacapavir, which interfere with the viral capsid at several points in the cycle. The strategy is usually to hit the virus at multiple steps simultaneously. Diagnosis and monitoring.
All right, let's switch to diagnosis. How might someone present initially? What are the signs, and how do we actually confirm an infection for the NAPLX?
Well, a significant number of people, maybe over half, experience what's called acute retroviral syndrome, or ARS, usually within about 2 to 4 weeks after getting infected.
What does that look like?
It often feels a lot like mono or a bad flu. Think fever, sore throat, swollen lymph nodes, maybe a rash, muscle aches, fatigue, night sweats, weight loss, sometimes diarrhea or nausea.
So pretty nonspecific symptoms.
Very nonspecific, which is why it can be missed. During this phase, the viral load is typically very high, and the CD4 count might dip temporarily. Then these symptoms resolve on their own, and the person might feel fine for years, even while the virus is damaging the immune system silently.
So you can't rely on symptoms alone. How do we test?
Right. The CDC recommends screening pretty broadly, at least once for everyone aged 13 to 64, and then annually for people considered high risk.
High risk being?
People with multiple partners, men who have sex with men, people who inject drugs, those with a partner living with HIV, etc. Screening is also recommended during every pregnancy. It's usually done using an opt-out approach.
Meaning testing happens unless the patient explicitly declines.
Exactly. Now, the testing algorithm itself is important. It usually starts with a screening test, often a rapid point-of-care test, POCT, or a lab-based test. If the screen is positive, the confirmation step now uses a fourth-generation laboratory HIV antigen-antibody combination immunoassay. This test detects both HIV antibodies and the P24 antigen, which appears earlier than antibodies.
So it can detect infection sooner.
Yes, it shortens the window period compared to older antibody-only tests. If this fourth-gen test is reactive, the next step is an HIV-1, HIV-2 antibody differentiation immunoassay.
To figure out which type of HIV it is.
Correct. If the results are unclear or indeterminate, then a nucleic acid test, NA, which directly detects the virus's RNA, is used.
And what about that window period you mentioned?
That's the time between infection and when a test can reliably detect it. Even with fourth-gen tests, there's still a short window, maybe a couple of weeks, where someone could be infected but test negative. So if exposure risk is high, retesting might be needed.
Okay, diagnosis confirmed. What baseline labs are essential before starting treatment? This seems like prime NAPLX territory.
Definitely. You need a comprehensive picture. Key labs include CD4 T-cell count, both absolute number and percentage, and plasma HIV RNA level, which is the viral load. You also need a complete metabolic panel, CMP, to check kidney and liver function, blood glucose, a complete blood count, CBC, a lipid profile, and a urinalysis.
What about resistance?
Crucial. Genotypic resistance testing should be done baseline if the viral load is over 1,000 copies ml. Some guidelines say consider it even between 500 and 1,000. This checks for pre-existing mutations that could make certain drugs ineffective.
And other infections?
Yes. Screen for sexually transmitted infections, syphilis, chlamydia, gonorrhea, trichomoniasis. Test for tuberculosis, TB, either with a skin test or an IgRA blood test. And check hepatitis A, B, and C serologies because co-infection is common and affects treatment choices.
Anything else specific to certain drugs?
Yes. If you're even thinking about using a Biktarvy, you must test for HLA-B5701. A positive result means the patient absolutely cannot take a Biktarvy due to a high risk of a severe hypersensitivity reaction. And if you're considering the entry inhibitor Maraviroc, you need tropism testing to see if the patient's virus uses the CCR5 coreceptor.
Wow, that's a lot baseline. Okay, so once treatment starts, how do we monitor progress?
Routine monitoring mainly focuses on two things: viral load and CD4 count.
Viral load first. Goal is undetectable.
Exactly. Undetectable, usually defined as less than 20 or sometimes less than 50 copies ml, depending on the assay. We want to see the viral load drop significantly after starting ART and become undetectable, ideally within 6 months. It's important to use the same lab and assay for consistent tracking.
And CD4 count?
CD4 count reflects immune system health. We want to see it increase with effective treatment. A normal count in adults is roughly 500 to 1,600 cells R. Monitoring helps assess immune recovery and risk for opportunistic infections.
Is there a specific CD4 level that defines AIDS?
Yes. AIDS is diagnosed if the CD4 count drops below 200 cells L, or if the CD4 percentage is less than 14%, or if the person develops certain specific opportunistic illnesses called AIDS-defining conditions, like pneumocystis pneumonia or Kaposi sarcoma, regardless of their CD4 count.
Okay, good distinction. Time for a quick checking question for our listeners. Which test is used to confirm a positive fourth-generation HIV screen?
That would be the HIV-1, HIV-2 differentiation immunoassay. Prevention strategies.
Okay, let's shift to prevention. It's just as vital as treatment. What about non-drug strategies?
Absolutely. The most effective way is abstinence, obviously 100% effective, but realistically, consistent use of barrier methods like condoms, male or female, significantly reduces risk. We're talking around 80% reduction for heterosexual transmission, maybe slightly less, around 70% for MSM.
Other behavioral things.
Yes, reducing the number of sexual partners, especially those with unknown HIV status. And importantly, getting tested and treated for other STDs helps because STDs can make it easier to get or transmit HIV.
What about preventing parenteral transmission?
Primarily, avoiding injection drug use. If that's not possible, using sterile needles and syringes for every injection is critical. In healthcare, strict adherence to universal precautions and using PPE protects workers from needle sticks.
And for perinatal transmission, preventing mother-to-child spread.
The cornerstone is screening all pregnant individuals and ensuring those who are HIV positive receive effective ART throughout pregnancy, labor, and delivery. This drastically cuts the risk. There's also careful consideration around infant feeding. If the mother maintains an undetectable viral load on RT, breast chest feeding might be an option after shared decision-making. But if the mother isn't virally suppressed, formula feeding is the safest route to prevent transmission.
Okay, now for the pharmacological prevention. Pre-exposure prophylaxis, big topic.
Huge. Pre-P involves HIV-negative individuals taking specific antiretroviral medications before potential exposure to prevent acquiring HIV.
What are the options?
The main options are daily oral pills. Tenofovir disoproxil fumarate plus emtricitabine, brand name Truvada and generics, and tenofovir alafenamide plus emtricitabine, brand name Descovy. There's also a long-acting injectable option. Cabotegravir, brand name Apretude, given every 2 months after initial loading doses.
Who should be considering pre-P?
Individuals at substantial risk. This includes people with multiple sexual partners, especially if condom use is inconsistent, those in serodiscordant relationships where the partner living with HIV doesn't have a suppressed viral load, people who inject drugs and share equipment, or anyone who's had a recent bacterial STI.
Are there requirements before starting?
Yes, absolutely critical. The person must have a documented negative HIV test right before starting pre-P, and they need regular HIV testing while on it, typically every 3 months for oral pre-P and before each injection for cabotegravir. You can't prescribe more than a 90-day supply of oral pre-P without confirming a negative HIV test result.
How effective is it?
Extremely effective if taken consistently. Studies show daily oral Prevep reduces the risk of getting HIV from sex by about 99%. For people who inject drugs, it reduces the risk by at least 74%. The injectable is also highly effective. Adherence is everything with pre-P.
Okay, NAPLEX focus time again. Which pre-P option is approved for people assigned female at birth who are at risk through vaginal sex?
That's an important distinction. Currently, Truvada, TDF-FTC, and injectable cabotegravir are approved for this population. Descovy, TF-FTC, is not currently indicated for individuals at risk through receptive vaginal sex because specific effectiveness data in this group is lacking.
Good to know that detail. Now, what if an exposure has already happened?
That's where PEEP, post-exposure prophylaxis, comes in. This is taking RT after a potential exposure to try to prevent infection from taking hold.
Is it different for workplace exposure versus, say, sexual exposure?
Yes, there's occupational PPE, OPEP, for healthcare workers, and non-occupational PPE, NPPP, for exposures through sex or shared needles. The principles are similar, though.
Key points for P.
It needs to be started as soon as possible, ideally within hours and absolutely within 72 hours of the exposure. The sooner the better. It involves taking a 3-drug ART regimen, sometimes 2, but usually 3.
For how long?
For a full 28 days or 4 weeks.
What's a typical NPP regimen?
A common preferred NPP regimen is tenofovir TDF plus emtricitabine, Truvada, once daily, plus dolutegravir once daily, or Truvada plus raltegravir twice daily.
And for occupational exposure, OPEP.
A preferred OPEP regimen is often tenofovir TDF plus emtricitabine plus raltegravir twice daily. Regimens might be adjusted based on the source patient's known resistance patterns, if available.
And follow-up testing is needed after PP.
Yes, follow-up HIV testing is crucial at baseline, 4 to 6 weeks, 3 months, and sometimes 6 months after the exposure to confirm if infection was prevented.
All right, let's test that. Which regimen is generally recommended for non-occupational PP-NP?
A preferred one is Truvada, representing TD femtricitabine, plus either dolutegravir once daily or raltegravir twice daily, taken for 28 days.
Antiretroviral therapy.
Okay, let's pivot fully into treatment now. RT has been truly transformative. What are the main goals when starting someone on therapy?
The overarching goals are pretty clear. Reduce HIV-related illness and death, improve quality of life, restore and preserve immune function, and importantly, prevent transmission to others.
How do we achieve that? What's the target?
The key is achieving and maintaining maximal and durable suppression of HIV replication. Clinically, this means getting the viral load to undetectable levels, usually below 20 copies per ml.
And you mentioned preventing transmission. This brings us back to that powerful concept.
Yes, UOU, undetectable equals untransmittable. This is a cornerstone of modern HIV care and messaging.
Remind us what it means exactly.
It means that a person living with HIV who is on effective RT and maintains a sustained undetectable viral load, typically defined as less than 200 copies per ml for this purpose, cannot sexually transmit the virus to an HIV-negative partner. Zero risk.
That's incredible. It must have huge implications for reducing stigma, too.
Absolutely massive. It empowers people living with HIV and helps combat fear and misinformation. So the guidance now is to start RT as soon as possible after diagnosis, regardless of CD4 count.
Are there any exceptions to starting immediately?
Very few. Sometimes, if someone has certain severe opportunistic infections like cryptococcal meningitis or TB meningitis, there might be a brief delay in starting ART to avoid complications from immune reconstitution inflammatory syndrome, or IRIS, but generally rapid start is preferred.
Okay, so what drugs do we actually use? What are the recommended initial regimens for most people?
Current guidelines strongly favor regimens built around an integrase strand transfer inhibitor, NSTI. The typical recommendation for most treatment-naive adults is 1 NSTI plus 2 NRTIs.
Can you give some specific examples? Those brand names often pop up.
Sure. Highly recommended initial options often include Biktarvy, which is a single tablet containing Biktarvy, an NSTI, entristabine, NRTI, and tenofovir alafenamide, NRTI. Another common one is Triumeq, a single tablet with dolutegravir, NSTI, abacavir, NRTI, and lemivudine, NRTI. But remember, Triumeq requires that HLA-B 57701 testing is negative and the person doesn't have chronic hepatitis B.
What if those single pills aren't suitable?
You can use multi-pill regimens. For instance, dolutegravir, NSTI, plus a 2 NRTI combination like tenofovir, either TDF or TF, plus entristabine or lemivudine.
Are there any recommended 2-drug regimens for starting therapy?
Yes. That's a newer development. The combination of dolutegravir plus lemivudine, DTG3DC, brand name Dovato, is now recommended as an initial option for some people.
Who shouldn't start on that one?
It's generally not recommended for initial therapy if the person has a very high viral load, over 500,000 copies per ml. If they have hepatitis B co-infection, because lemivudine treats hep B but isn't sufficient alone. Or if you need to start ART before getting the results of resistance testing or hepatitis B tests back.
You mentioned single tablet regimens like Biktarvy and Triumeq. Are they generally preferred?
Yes, when appropriate. Single tablet regimens, STRs, simplify the dosing schedule, usually just 1 pill once a day.
Yeah.
This has been shown to significantly improve adherence compared to taking multiple pills, and better adherence leads to better long-term outcomes.
Makes sense. Less pill burden is always good. Quick question then. Thinking about the goal, how quickly should we expect the viral load to become undetectable after starting RT?
The goal is generally to achieve an undetectable viral load in less than 6 months, often much sooner, within 8 to 24 weeks for many people on modern regimens. Key side effects and drug interactions.
Okay, we know the regimens. Now for the really crucial pharmacist part, side effects and interactions. This is high yield for the NAPLEX, right?
Absolutely critical. Let's hit some key ones. First, tenofovir. It comes in 2 main forms: TDF, disoproxil fumarate, and TMF, alafenamide.
What's the difference in side effects?
TDF has known risks of nephrotoxicity, kidney problems, and decreased bone mineral density. TAF was developed to have less impact on kidneys and bones. It achieves high concentrations inside cells with lower levels in the blood plasma, leading to generally improved renal and bone safety profiles compared to TDF.
So TAF is generally preferred for safety.
Often, yes, especially in patients with pre-existing kidney issues or osteoporosis risk. However, TAF has been associated with slightly more weight gain and potentially less favorable lipid changes compared to TDF in some studies.
Okay. What about abacavir? We mentioned the HLA testing.
Yes, the absolute contraindication in HLA-B5LA701 positive patients because of the risk of a potentially fatal hypersensitivity reaction, HSR. Symptoms often include fever, rash, fatigue, nausea, vomiting, diarrhea. Abdominal pain can be multisystemic. It's critical to counsel patients to stop abacavir immediately and never restart it if HSR is suspected.
And you also mentioned a heart risk.
Yes, some data suggests an association between abacavir and an increased risk of myocardial infarction, MI, particularly in people with underlying cardiovascular risk factors. So it's often avoided in those patients too.
Got it. What about the boosters, ritonavir and cobicistat?
Right. Ritonavir, RTV, and cobicistat, are primarily used as pharmacokinetic enhancers, not for their own antiviral activity at the doses used for boosting. They are potent inhibitors of the CYP3A4 enzyme.
Meaning they increase the levels of other drugs.
Exactly. They boost the levels of certain protease inhibitors like darunavir, idazanavir, or the integrase inhibitor elvitegravir, allowing for less frequent dosing or lower doses of the main drug. But this CYP inhibition also means a high potential for drug interactions with many other medications.
Okay, that's a big red flag for interactions. Any key issues with the NSTIs like dolutegravir?
Dolutegravir, DETG, has had some safety signals. There was initial concern about a potential increased risk of neural tube defects if taken around the time of conception. Though more recent data has been somewhat reassuring, the caution remains, especially in early pregnancy. It can also cause side effects like insomnia, headache, and rarely more severe neuropsychiatric events, especially in those with pre-existing psychiatric conditions. It can also increase creatinine kinase, CPK.
What about other classes? General side effects for NNRTIs or PIs?
Sure. NNRTIs as a class, particularly older ones like efavirenz, are known for neuropsychiatric side effects: dizziness, drowsiness, vivid dreams, depression, even suicidality. Rash is also common. Newer NNRTIs like doravirine tend to be better tolerated. Protease inhibitors, PIs, often cause GI intolerance. Diarrhea is very common. They can also lead to metabolic issues like dyslipidemia, abnormal cholesterol, triglycerides, and insulin resistance over time. Drug-induced hepatitis can occur, and specifically adazanavir can cause hyperbilirubinemia, leading to jaundice, a yellowing of the skinnies, and sometimes kidney stones.
That covers a lot of specific drug issues. What about general types of drug interactions we absolutely need to watch for?
The CYP450 system, especially CYP3A4, is huge. As we said, ritonavir and cobicistat are potent inhibitors. Many PIs are also inhibitors or substrates. Some NNRTIs, like efavirenz, etravirine, and nevirapine, are inducers of CYP enzymes, meaning they can decrease levels of other drugs.
So checking for interactions is always necessary.
Always. Another big one is drugs affected by gastric pH. Adazanavir and ropivirine, an NNRTI, need an acidic environment in the stomach to be absorbed properly.
Right.
So drugs that reduce stomach acid, like proton pump inhibitors, PPIs, or even H2 blockers and antacids, can significantly lower their levels and risk treatment failure.
Okay, pH matters for some drugs. Anything else common?
Yes, polyvalent things like calcium, magnesium, aluminum found in antacids, iron supplements, multivitamins containing minerals. These can bind to NSTIs, Biktarvy, dolutegravir, elvitegravir, raltegravir in the gut and prevent their absorption.
How do you manage that?
You need to separate the dosing. Usually the NSTI should be taken either 2 hours before or 6 hours after the cation-containing product. It's a really common interaction to counsel on.
Definitely sounds like it. Okay, let's do another specific safety check. A patient tests positive for HLA-B5701. Which antiretroviral drug must be avoided?
That's abacavir. Absolutely avoid abacavir. Special populations and adherence.
We need to consider specific patient groups, too. What about kids or people with kidney or liver problems?
Right. For pediatrics, most children with HIV are diagnosed asymptomatically through screening. ART should be started right away. The principles are similar to adults, usually 2 NRTIs plus an NSTI, a boosted PI, or an NNRTI. But dosing is obviously weight-based and formulations can be tricky. Zidovudine, AZT, is still often used in newborns born to HIV-positive mothers to prevent perinatal transmission.
And renal or hepatic issues.
For renal insufficiency, we already mentioned the caution with TDF. TAF is often preferred. Most NRTIs require dose adjustment based on kidney function, with the notable exception of abacavir, which doesn't need renal adjustment. Also remember that cobicistat, dolutegravir, and bictegravir can inhibit creatinine secretion in the kidney tubules, causing a small, generally benign increase in serum creatinine that doesn't reflect actual kidney damage, GFR change. For hepatic insufficiency, PIs, especially those boosted with ritonavir, need caution as they're metabolized by the liver. Nevirapine, an NNRTI, carries a boxed warning for severe, potentially fatal hepatotoxicity, with risk being higher in women with higher CD4 counts and men with higher CD4 counts at initiation.
What about pregnancy? Key considerations there.
Testing in the first and third trimesters is standard. RT is strongly recommended for all pregnant individuals with HIV, regardless of their CD4 count or viral load, primarily to prevent mother-to-child transmission, but also for the mother's health.
Are there preferred regimens during pregnancy?
Yes. Guidelines recommend specific regimens with good efficacy and safety data in pregnancy. Preferred options often include NSTIs, like dolutegravir or raltegravir, or boosted PIs like darunavir-ritonavir, combined with the preferred 2 NRTI backbone, often abacavir-lamivudine, TD-femtricitabine, or TD-flamivudine. Telfemtricitabine is now also considered. Dolutegravir use around conception requires careful discussion about the neural tube defect risk, although it's considered a preferred agent during pregnancy itself.
And adherence is paramount here too.
Absolutely critical. Maintaining viral suppression throughout pregnancy dramatically reduces transmission risk. Delivery method also depends on viral load. Vaginal delivery is typically recommended if the viral load is n 1,000 copies ml near delivery.
We've mentioned adherence multiple times. It seems like the absolute linchpin for success, doesn't it?
It is the most critical factor. You can have the best drugs in the world, but if the patient doesn't take them consistently as prescribed, the virus will replicate, resistance will develop, and treatment will fail. Assessing readiness and willingness to adhere and addressing any barriers has to happen before starting therapy and continuously throughout treatment. Outro.
Wow. Okay, that was a true deep dive. We've covered a massive amount of high-yield ground, the nature of HIV, how it spreads, the intricate life cycle, and drug targets.
The modern diagnostic and monitoring strategies focusing on viral load and CD4 count, the critical prevention tools like PrEP and PIASA,
and the evolution of art that allows people to live long, healthy lives, plus those crucial side effects and interactions.
Yeah, just to quickly recap some super key NAPLEX points. Remember, HIV is an RNA retrovirus. Know the 3 main transmission modes. Viral load and CD4 are your key monitoring tools. Acute HIV can look like mono. PrEP works incredibly well with adherence. Maternal ART drastically cuts perinatal transmission. Combination RT is standard. Initial therapy is usually 2 NRTIs plus an NSTI.
Ritonavir and cobicistat are boosters. Watch for CYP interactions with PI and NRTIs. Acid blockers affect atazanavir pivirine. Separate NSTIs from medications.
Start ART in pregnancy. And remember, TI-5 generally has a better renal bone safety profile than TDF. And avoid abacavir if HLA-B5701 positive.
You've just absorbed a ton of information that's not just for the exam, but for understanding a field where science truly meets compassion. And maybe final thought for you to ponder. Consider how that UU principle, undetectable equals untransmittable, doesn't just change medical facts. How does it actively challenge the stigma that has surrounded HIV for so long? And how might that transform conversations you have with patients or colleagues?
It's a powerful shift.
It really is. Okay, if this deep dive helped clarify HIV pharmacotherapy for you, please do take a second to like this video and subscribe to the channel. It helps us reach more learners like you.
Your support makes a difference.
Thanks so much for tuning in and investing your valuable time in learning today. HIV care is more than just a test topic. It's where your knowledge can genuinely impact lives. If you learn something new or feel a bit more confident for the NAPLEX, definitely subscribe, maybe share this with a classmate, and feel free to drop a comment about what topics you'd love us to tackle next.
You appreciate the feedback.
Until next time, stay curious, keep putting in the work, and be kind to yourself through this process. You're doing great.